Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Your host, Dr. George Netto, is the editor-in-chief of Modern Pathology and the chair of pathology at the University of Alabama at Birmingham. Here's Dr. Netto.
Greetings, ModPath Chat followers. It's my great pleasure today to host Dr. Carlos Parra-Herran from the Department of Pathology at the Brigham and Women's Hospital. Carlos is an expert gynecologic pathologist with a special interest in vulvar lesions. We will be discussing his group recent review in modern pathology on really the increasingly complex morass, I would say, of vulvar intraepithelial neoplasia. Thank you, Carlos, for accepting my invitation.
Thank you, Dr. Netto, for the invitation. It's really an honor. I've heard previous versions of your podcasts, and I've seen, the caliber of the people that you get to chat with. And so it's quite humbling to be here with you today.
It's our honor, and it's all about the next generation pathologists promoting their work. And of course, it's never a one-man show. So they have with you Dr. Marisa Nucci, Dr. Blake Gilks, and a lot of prominent pathologists and Brookowitz. So we really appreciate this. Is a very valuable review. So Let's start with, as we usually do, setting the background. Why did you need to do this review? What's going on with VIN, I guess the name? Yeah, vulvar.
Yeah. So the review started as really some degree of inconformity with the current nomenclature, and that has existed for a while. And I think it was the main driver to the shifts in the classification of intraepithelial precursors and carcinomas in the lower genital tract. And that includes not only vulva, but also vagina and uterine cervix, in which we now know that there is a subset of HPV-associated lesions, but there is an important subset of HPV-independent lesions. And we've not done for a while, but interestingly enough, the nomenclature seen from that angle has been somewhat problematic over the years. And to that, I'll say that I'll reinforce the point that you made, that there is not one person's show. It never is anymore. And I'm thankful to work with very talented pathologists at my institution. I started the conversations with Marisa Nucci, and Jacqueline Watkins, who works also here in Boston at Mass General Hospital, and who has also worked extensively in this particular topic. And we shared some ideas about what will be the best way to integrate this particular set of lesions that the review focuses on into the existing classification. And the next step was to involve people that are also experts in vulvar pathology, but more importantly, that were engaged in the development of the current classification from the WHO. So I invited people that contributed to the chapters on HPV-independent vulvar intraepithelial neoplasia to come up with a name and to come up with a contemporary concept of these lesions. Why are they so problematic? Well, there are several layers to it, but the most important problem with it is that the names that have been proposed for these lesions have changed over the last 20 years. It's been interesting to see the adoption of those names by the literature and by the community, but also the varying levels of confusion that they generate just because there's so many, right? And at some point, they probably referring to the same thing, but we are not sure. So it is that confusion that lingers in the community what motivated us to do this.
So let me interject here and clarify to our audience. So we're focusing on intraepithelial lesions that are, again, HPV independent and we'll talk a little bit about the molecular underpinnings of those. But the names, and you mentioned that, and I'm not surprised there was no good adoption and agreement. When you come up with names like devil, VAAD, like double VAAD, double AD,
Yeah.
vLSC, lichen sclerosis, chronicus, like vulvar lesion. I mean, wow, this is, and I remember there was a study last year on the topic, and actually we did a podcast on, or end of the year podcast. So you're saying these didn't catch on, or at least there's so much confusion because there's so many names, who's calling what, right?
Yes. So, well, the problem, we see these, sometimes in other sites or with other lesions. That I think the issue is these names have emerged in the literature primarily to describe a lesion based on their morphologic features. So vulvar acanthosis with altered differentiation, which was the first term coined by Dr. Christopher Crum to describe these lesions, is purely morphologic, right? It's just, you read the 4 words and it's telling you everything you need to know about how this lesion looks under the microscope. Exactly. Right. So that was the very first step, and it's a valuable one because this is a lesion that is primarily more based on morphologic diagnosis. Then over the years, we've gradually learned a little bit more about these lesions, right? Like the second name that Dr. Crum proposed, which is DEVIL, differentiated exophytic vulvar intraepithelial lesion, was a name in which he analyzed cases that fell within the spectrum of VAAD, but also within the spectrum of Verruciform lichen simplex chronicus and other Verruciform atypias, all described, as all these names imply, all described purely based on morphology. And what his second paper on DEVIL, written with Jacqueline Watkins, suggests is that these lesions not only have a morphologic denominator, but also a particular set of genomic alterations, particularly PIK3CA, HRAS mutations, RET2, and a link, temporal and spatial link to squamous cell carcinomas of the vulva. And that's why this lesion is biologically important. It's not, it's not the fact that it's verruciform and it may be symptomatic or clinically visible. It's the fact that it's associated with vulvar squamous cell carcinomas. VAAD was initially linked to verrucous carcinomas of the vulva, and then DEVIL kind of expanded on that relationship by documenting cases that presented synchronously with squamous cell carcinoma or that presented later with a conventional squamous cell carcinoma. And then literature after that has kind of built on that, like several other genomic alterations have been described, and the link in case series between these lesions and squamous cell carcinoma has been confirmed by independent series, and that's when we come in, where our group felt that even though these lesions are so rare, there is sufficient evidence to treat them or to start conceiving them as a form of an epithelial precursor, namely vulvar intraepithelial neoplasia. And so it's kind of, we thought it was a good time to integrate this particular lesion, into the current nomenclature of the WHO, meaning HPV-independent, within the HPV-independent group of lesions. It's not only HPV-independent, but it's also P53 wild type, which is the other part of the name. Because we've known for a while that there is a subset of HPV-independent lesions that have alterations in P53, are P53 mutant, and morphologically we've known those lesions as differentiated VIN, and they have a very different clinical behavior and a much stronger link to squamous cell carcinoma progression. This particular set of lesions that started with VAAD and then moved into DEVIL, and then Verruciform lichen simplex chronicus, and more recently vulvar altered maturation, belong to their own group, and that's why basically what we're basically trying to describe in the review.
So to simplify to someone like me, although we have similar problems with the penile lesions, and interestingly, rereading your paper, I kept thinking about a case I signed recently where, again, it wasn't P16 and it looked very verrucous, but it's invasive. So probably we're finding more and more there are counterparts and parallels between penile, not surprisingly, and vulva lesions. So, but here, so all these morphologic, and I was joking about these different terms. And if you're a giant like Dr. Crum, you can create as many terms as you want, and I'm sure it would be very helpful. And descriptive terms a lot of time are helpful. But you're saying now that we know what is morphologic, and now we're gonna break them down into P53 positive, mutated, or P53 not. But is the morphology of every subset a little different? So define for us the morphology of what you focused your topic on.
Okay, yeah, and this is also a very hot topic, I would say, because when you're talking about a vulvar intraepithelial precursor, some people will rely purely on morphology for their classification, and some people will increasingly use immunohistochemistry to further subdivide it. And I have to disclose that the group that wrote the review with me, including myself, are probably on the second camp of people that will support their diagnosis with immunohistochemistry more often than not. And the reason for that is when it comes to identifying a differentiated VIN or HPV-independent VIN, morphology can only take us so far. There is a number of cases in which we'll make the wrong diagnosis if we just base it on the H&E. And the biology is driven more than the H&E, is driven more by the biology of it, meaning does it have a P53 mutational signature or not? So with that angle, the lesions that Dr. Crum describes as VAAD and then devil, and this particular set of lesions that we now describe as acanthotic and verruciform VIN are number one, lesions that occur in older women. And by older women, I mean after the 5th, 6th decade of life. Most patients present in their 60s, 70s, 80s. They may have a history of a chronic dermatosis like lichen sclerosus, but that's not always the case. And they present with a discrete plaque-like or verruciform type lesion in the vulva. It's typically single and unilateral, but it has discrete borders. Sometimes when we receive the biopsy or the excisional specimen, the question is like, is this a verrucous carcinoma, or is this a well-differentiated squamous cell carcinoma? And these lesions fall short of that because they're purely intraepithelial, right? They don't have endophytic or conventionally invasive front in the underlying dermis. They look like they're confined to the epidermal compartment, but they're thick. So that's the feature number 2. So the first one was the age and the clinical presentation. The second one is the very classic verruciform morphology. So they look thick, very acanthotic. They can be flat or plaque-like, or they can be exophytic with church spire-like projections into the lumen, and also a similarly irregular and elongated interface of the rete ridges with the dermis. Feature number 3 will be the lack of atypia, and that distinguishes these lesions from conventional intraepithelial lesions like HSILs, HPV-associated, and differentiated VINs, which are P53 mutant. They both are characterized by varying levels of nuclear atypia, which is something you don't see in these verruciform acanthotic VINs. Number 4 will be the absence of P16 overexpression and absence of abnormal P53 staining pattern on IHC. And that's basically how we defined it.
So just to follow up, so you do P16. If it's negative, you don't bother doing HPV?
In the vulva, yes, correct. And that's pretty much what the WHO says. P16, at least in this anatomic region, seems to be quite a reliable surrogate for HPV status. Actually, HPV testing, either IHH or PCR, could give you false negatives if the RNA quality, if the DNA quality is not good. So there's studies that claim that P16 is even superior or more sensitive to HPV techniques to identify HPV status. So I think, and that added to the fact that P16 immunohistochemistry is widely available, is significantly cheaper, easier to interpret. That has all led to the WHO classification proponents and most people in the community to accept and embrace P16 as a surrogate of HPV.
Excellent. I mean, and the idea is clearly the more we can adopt biomarkers that are available all across the world is better because not everywhere they have the expensive, technology of ISH or FISH, what have you. So you do basically you do P16, you do P53, and you show that is negative in a wild type. And the morphology that you're describing and the age and the clinical setting, and you're done, and then you call it the new name you're proposing. Is that correct?
Pretty much. I think the second main message of the review is this is basically, and this is how I conceive it right now, in a way it's a diagnosis of exclusion because it is rare. And there are things that you need to exclude, and immunohistochemistry helps you with that. Like you need to exclude other forms of VIN. But there's another set of lesions that you should also think about. Lesions that will give you acanthosis or verruciform acanthosis, but are not quite neoplastic. So, for example, psoriasis, certain forms of pseudoepitheliomatous hyperplasia, that are forms of epithelial hyperplasia in the vulva secondary to infection or granular cell tumors, verruciform xanthomas. They can all look verruciform or acanthotic, and of course, you should think about those before you stamp it as verruciform acanthotic VIN. And that's why I emphasize on the clinical presentation. Verruciform acanthotic VINs are typical of older women. Psoriasis and infectious conditions will be more likely to present at younger ages. Syphilis can give you, in its primary form, can give you a plaque-like hyperkeratotic lesion in the vulva or in other parts of the genitals. And but the clinical presentation will be different. It will deviate from the typical presentation, the age distribution that we see in these lesions.
Excellent.
And there are other morphologic clues that we describe in the paper. But to answer your question, there is a wider differential diagnosis that you need to think about.
But once you decided this is a pre-neoplastic or intraepithelial neoplasia, then these two immunos and the morphology should help you. And it sounds like from when you're talking about, you're using vaVIN, small v, small a VIN, and verruciform acanthotic VIN as a terminology, at least descriptively, to replace the previous. But then then you do these two markers, and then you're proposing if the HPV is negative and P53 is wild type, then you call it HPVi, which is independent, P53WT, which is P53 wild type, vaVIN. Is that correct?
Yes, correct. So if you read the paper, the name of HPV-independent P53 wild type, verruciform acanthotic, vulvar intraepithelial neoplasia is a mouthful. It's exactly. It's exhausting to say it.
Yeah, I'm tired already. Right. But I'm not a GYN pathologist, so it's okay.
Well, I'm tired of saying it.
That's awesome. This is really interesting, and I try to make the conversation fun, but shouldn't take away from the importance of this identity. It's not negligible. Differentiating these different subtypes is very important because tell me why? Because you just mentioned the P53 ones, positive ones, for example, are more likely to progress. So now that we're all going to call it HPVi P53 wild type vaVIN, what should we expect for our patients who have it? And what's therapy beyond is it just excision, which I expect?
That is a great question, and the recommendation is largely based on what retrospective series have documented on these patients, which unfortunately is really scant. Like we don't have literature or evidence on prospective management of patients that have these lesions. Because we've known them for a while, I think everybody makes a diagnosis of VAAD or devil. There is some sort of urgency to implement at least long-term follow-up and surveillance of the vulva. But most centers and the evidence documented in most series show that our treating colleagues opt for conservative excision of the lesion. So for the time being, a diagnosis of Verruciform acanthotic then should trigger conservative excision if it's present on just on a biopsy with negative margins. We don't know yet how wide needs the margin to be, but conservative excision is what has been observed in most of these series and is what seems to be prudent in most cases. Otherwise, if excision is or evaluation by a gynecologic oncology specialist is not possible, at the very least, close surveillance with monitoring and sampling of any new lesions should be considered. The issue of the management was raised by our review is relatively new, but it already has a letter to the editor. Which was recently published, and we can dive on the background of that. But one of the points the letter raises is the challenges with the management, which we completely acknowledge. Like these lesions are rare enough and still enigmatic to a point that we need to learn how to treat them. But we know that these lesions have neoplastic properties and have at least an epidemiological association with squamous cell carcinoma. So that's why most people become more comfortable with excising it.
I refer our audience and viewers to figure 3 in the paper, which really just looking at those pictures, it's exactly the wording you were described, the six examples that you listed. Yeah. Beautiful images. And to finish, let's. I think we've already gone beyond time, but this is so enjoyable. You're a great host, a guest, and
thank you. You're a great host.
Thank you. And I'm wondering, in your mind. So now we have the VIN that is HPV dependent, and those that are independent, the usual or the differentiated. We used to call them usual before. The differentiated one, which are P53 positive, and this. How do you rank them in terms of what, in your mind, more aggressive, more likely to progress or not? All these 3 categories.
The differentiated VIN, or what we will classify as HPV-independent P53 mutant. Again, let me insert the caveat that not everybody equates differentiated VIN with P53 mutant. But I think that's a field that is also evolving, and I sense that there is a push by the WHO to increasingly consider P53 as part of the spectrum of differentiated VIN, and I completely believe in that. Those cases, the ones that have abnormal P53 patterns and are HPV independent, are the bad players. Are those that need to be treated, need to be excised with wide negative margins, because the association, the temporal and spatial association with squamous cell carcinoma, and the prognosis is much worse. We know that we've known that for a while, and it remains the case.
So yes, these are a little better.
That's the one you really need to worry about.
Excellent. Thank you. I guess one more question before we get closed. To clarify to our audience, P53 mutant, it's either overexpression, tell us, and null, and OVAD, correct? Similar to other organs.
Yeah, yes, I could stay here.
Or does that need another podcast?
I think so, actually, because at least in the GYN world, like that's how we conceive P53 is either overexpressed or completely absent, which is the null pattern, and then the very rare cytoplasmic staining pattern, right? If you have a solid neoplasm, like a high-grade serous carcinoma, that's kind of how you interpret it. But when you're dealing with a squamous epithelium, the location of the staining pattern matters a lot. So when we talk about overexpression, the overexpression can be basal only. So strong staining in the basal layer only. That's a mutational pattern. Or a strong staining that is present at the base, but then it extends into the upper layers. Sometimes it's full thickness. That's also an abnormal pattern. And then you have the absent and the cytoplasmic patterns. Wild type staining, which is the normal staining for P53, is like the heterogeneous nuclear staining that you need to see at the base. And then eventually it becomes negative in the superficial squamous cell layers. The P53 protein gets degraded, so you won't really see it. But you need to see that heterogeneous kind of weak to moderate staining at the base to reassure you that that's a normal pattern.
Carlos, unbelievable how much knowledge you provided to our audience and to me personally. I really thank you for taking the time. Although this will be broadcasted later, we are a few days from Christmas, so happy holidays, and really enjoyed having you. And thank you again for supporting the journal, for providing such important reviews to our audience, and for coming on.
Thank you, Dr. Neto, for considering the paper, number one, and for doing so much for the journal, and most importantly, for giving me this space and this opportunity to talk about our work. It's a privilege.
It's a pleasure. So long, everyone.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Springer Nature, UAB, or USCAP. Your ModPath Chat host and scientific director is Dr. George Neto. Producers are Christina Crow, Amber Jackson, Dr. Sarah Jang, and Dr. Catherine Ketchum. Technical direction is provided by Kaminsky Productions, music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.